In my last video on fibroids, I mentioned the rare but significant risk of something called fibroid cancer, also known as leiomyosarcoma. How common is it and how much do we need to worry? Well, that's what we're going to unpack in today's video. Hi, I'm Dr. Rich, and my passion is to empower every woman with practical knowledge about the world of women's health. Cancer is a hard word, and it makes all of us anxious and uncomfortable. So I'm bringing my esteemed colleague and good friend from Orange County via Zoom, Dr. Marc Winters, to help provide accurate information regarding leiomyosarcoma. Welcome, Marc.
Thanks, Rich. It's a pleasure to be here. And cancer is not my favorite topic to talk about, but I think it's a necessary topic. And I think the more people know, the more information, the better we can all deal with this.
So tell us a little bit about yourself and your practice out in California.
Sure. I am a gynecologist in Southern California. I'm part of a large group called Orange Coast Women's Medical Group. We're a part of Hoag Clinic, which is one of the major hospitals here. I also serve as medical director of benign gynecology for Hoag's Women's Health Institute in Newport Beach in Irvine, California. My interests are really minimally invasive gynecologic surgery, robotic surgery, and that's kind of where I find my subspecialty in at this point.
And how much teaching are you doing these days? You did a lot, and we both do a lot, is mentor sites and epicenter sites for training. How much of that are you doing now?
So prior to COVID, we were still very active as far as a case observation site where people would come in and spend the day with me and watch surgeries. And then I did a fair amount of traveling as far as speaking, different locations, and doing some teaching around the country and occasionally out of the country. Since COVID hit, life has changed.
It has.
We're trying to do what we can virtually. We're actually looking at trying to figure out what kind of system we can install in the main hospital I'm at to make that more feasible. But I've been doing some virtual events periodically over the last few months, and speaking at a couple virtual conferences. So a new way of life.
Well, there's this new concept for surgical training, telementoring, where there's actually a large tower that goes into the OR and records the entire OR and also plugs into the surgical camera, and you can actually virtually mentor or virtually do a case observation. Have you done any of that? Has anybody approached you about that?
Yeah, actually, a couple people have approached me about that. I have not done any yet, but that's what I was kind of referring to. There's a couple different systems we're looking at that will enable that to be possible. So I'm looking forward to that in the near future. And in some ways, some of that's going to be better. I mean, it seems like you miss that personal contact, and it's nice to be there, yet you can still have a large impact and not have to leave, and not, I think in some ways it's going to be better.
I think so too. Well, I really appreciate you taking the time and joining us from across the country to talk about this very important topic. We have done a prior video, which you can check out here, on benign fibroids. And you and I have actually done another talk on this cancer fibroid, the leiomyosarcoma, on a separate podcast, which you can check out in the section below. Let me ask you, how rare or how common is leiomyosarcoma or cancer fibroid?
Yeah, that is a great question. There are ranges as far as how common is it really. What we thought in the past. Let me go back a little bit. Pre 2013, we thought it was extremely rare. maybe one in several thousand, one in 10,000 seemed to be the number that most people fixated on as far as the more serious cancers, these leiomyosarcomas. And then there was a case that was kind of the big incident case, or sentinel case, where there was a lot of buzz after that. And the FDA actually looked at that and held sessions to try to figure out how common was this, and was the instrumentation we were using to remove fibroids proper, which we were using what's called a power morcellator, which is an instrument with a circular blade that will cut tissue like this into thin little strips, so you can get big things out through little incisions.
So that would allow you to do a minimally invasive surgery through little tiny incisions and yet still be able to remove very large specimens, very large fibroids.
Exactly. And be able to remove these large specimens in a way where people could go home the same day and recover quicker and get back to work quicker and feel better much quicker. Plus, and we've done studies, we published one on hysterectomy. We showed that the complication rates doing it that way were actually lower,
Yeah.
and that we got better results doing things in that fashion.
So what did the FDA do about this power morcellator device?
Yeah, so they looked at it. They looked at a number of studies. I believe the number of studies at the time was about 9 studies, and they came out with numbers of approximately 1 in 350 of patients being operated on had a cancer.
That seems
And
way off.
Yeah, and 1 in 495 had these bad cancers, this leiomyosarcoma. Now, even though these numbers are much higher, they're still not super high, but it kind of made everybody pause. I had seen in my career, I think one of these after thousands of hysterectomies or myomectomies, and you know, as one surgeon, anecdotally, you can't really go by that. You need to go by studies. But what these studies failed to look at is all the women sitting out there who chose other types of procedures. You know, we have all these shrinkage procedures. The most common is uterine artery embolization, where a radiologist will catheterize the blood vessels leading to a large fibroid and put something in the blood vessels to occlude them so that the fibroids will shrink. There are some other procedures using focused ultrasound with MRI guidance, or cauterizing or freezing these fibroids to have them shrink. So all these people that chose alternate routes of treatment were not included. People who chose expected management, no surgery, were not included. And there's a number of patients we have with fibroids who say, hey, they're not growing significantly, they don't bother me, I'm just going to leave it alone. And then the big number is, there is a lot of women out there that have fibroids that don't know they have fibroids. We know, depending on the population, fibroids occur in 50 to 80% of women, depending on the population. So this is a huge number. So when we talk about this 1 in 495 of these bad cancers, that's not how often fibroids are actually cancerous. But of women choosing to have certain procedures, these are the numbers that came up.
It seems like they're losing a lot of cases from the denominator, of the equation, based on what you're saying, like people not knowing they have fibroids, the studies only including cases with patients who had a fibroid or a cancer. And because it's a pretty big difference from one day to say that fibroids are 1 in 2,000, fibroid cancers 1 in 2,000, and then the FDA comes out with a study and says all of a sudden it's 1 in 400.
Right, exactly. So the FDA actually re-looked at that in 2017, and they looked at 23 studies at that time. And it's interesting, they came up with a range of how often a leiomyosarcoma is there. And they said it was anywhere from 1 in 495, their original number, to 1 in 1,100. But again, This is 23 studies looking at certain aspects. None of these were population-based studies looking at a population saying, hey, we're going to check 10,000 women and see how often any of them have, how many of those have fibroids, and of those, how many have a leiomyosarcoma. So they weren't done in that way. But it just shows you what a range there are. There have been some other studies done. I think Bill Parker, who is well known for his work in fibroids, quotes a number of 1 in 3,000 as the incidence of leiomyosarcoma.
You and I, having done thousands of cases, I've had 2 leiomyosarcomas. You've had 1. Everywhere where we've, had the privilege of lecturing and educating, we take the opportunity to survey the audience, and that seems to be pretty congruent that most surgeons are seeing these things, most commonly 1 in 1,000, probably more realistically 1 in 2,000 or even more than that. But what did the FDA end up doing about this device that would assist in removing the fibroid through tiny little incisions?
So the FDA they didn't outlaw or remove the device from the market. They did put a black box warning just to warn doctors about the potential harm of the device, which is an interesting thing, and I'll get to that in a minute. But they warned about the harm of the device, and they suggested that women near menopause, so roughly 50 and older, think twice about having this device used with their surgery, and that for younger women that we should thoroughly counsel them about options and make sure that it's a mutual shared decision between the patient and us as to which way to take out the fibroid. As for us, it meant talking about alternatives to using a morcellator. And we actually have come up with some really good alternatives. Either what I think most of us now will put fibroids in an enclosed environment. We actually put a containment pouch inside the abdominal cavity where we can put the fibroids in that pouch and then remove the fibroid within the pouch, either by pulling the tissue up and cutting it into little pieces. But that cutting, the tissue all remains in that containment pouch, so it can't get thrown all around the body inside. And the other way is to still use a power morcellator, but again, within this containment pouch, putting a camera in from the side, kind of a tricky way, so we can look under direct visualization and still use it. But either way, keeping things in an enclosed environment. So the FDA actually encouraged using an enclosed environment to remove fibroids if it was being done in a minimally invasive way.
And what was the net result of this black box warning for your, average practicing physician? Did they have access to the morcellator, or pretty much it went away?
Yeah, pretty much went away in most places around the country. There are certain areas where it's still used in certain situations for when fibroids aren't there, or people who have adapted this contained approach. But for the most part, it's gone away. What's really interesting to me about that is a lot of surgery is being done. How to say, you and I have spent a lot of time, because this is our subspecialty, and we try to figure out what's the best thing for our patients. And we've taken the time to really learn these techniques. In fact, we teach these techniques to other physicians. So that's a difference where a lot of other physicians have said, you know what, I'm just not going to bother anymore. I'm just going to go back to doing things as an open procedure with big incisions, like a C-section kind of incision. So kind of interesting what that did. People looked at the net effect of that several years after that went into effect, and showed that the rate of open procedures, or with the big incisions, went up significantly, that the complication rate from hysterectomies went from 1.9% when you look at all major complications, 1.9% to 2.4%. So that 0.5%, it doesn't sound like that much, 1.9 to 2.4. But if you figure there's approximately 450,000 women having hysterectomies per year in the United States alone, that translates into approximately 2,250 women having major complications that otherwise would have been avoided had we still used the techniques we were using pre 2014.
So you're saying that for a lot of providers, it was too much of a challenge to learn a new technique, and in their hands, the safest thing to do was just to do an open incision. And although well-intentioned, the black box warning, the net effect of that was actually we increased complication rates nationwide simply by virtue of the fact that open surgery is associated with more complications than minimally invasive surgery.
Exactly. And that's been probably the biggest frustration of this whole thing. Yeah, we figured out ways, which I think a lot of us will say the ways we figured out are actually better than what we were doing before, as far as refining the minimally invasive techniques. But
I
for a
agree.
lot of women who aren't offered that, yeah, we're doing more harm than we were before, and that's very frustrating. I know for you it's frustrating, and me it's frustrating for those of us that try to teach as many people as possible to become better at minimally invasive techniques so they can offer that to more patients.
And you used the word harm, and I think it's important to kind of clarify where the harm is, because when the FDA statement came out, there actually was a great deal of confusion. Patients, a lot of them thought that somehow the power morcellator itself caused cancer, but the reality is that there's a rare cancer. It's called a sarcoma. It's a very bad type of cancer in the sense that survival rates are very low. We also do not have great treatments for sarcoma and leiomyosarcoma. And the unfortunate fact is that if someone has that diagnosis, they have a very low survival already. And that has nothing to do with the method in which it's removed. The issue, the harm, comes in when you use this device and you remove the fibroid in pieces, and as you mentioned, the pieces can then fall down inside the abdomen and it would spread the disease. So it's already a bad disease, but then it actually becomes a little bit worse because it's spread throughout the abdomen.
Yeah, exactly. And it's one of those things, even there's going to be some spread of cells just by doing any kind of surgery. And these devices in a non-enclosed environment can spread tissue. In fact, you can get I've seen this a couple times, something called leiomyomatosis, where pieces of fibroid will actually implant into that abdominal cavity and will grow and head to sometimes that can be a very challenging conditions or surgery afterwards. So that's one of the things about these bags I really like, because now we're not going to see that. But yeah, there were so many misconceptions when that came out that, oh, the morcellator is going to give me cancer. No, it doesn't work that way. And if you're that one in whatever that has that, it's one of those unfortunate conditions no matter what you do, because it's difficult to treat. There have been a couple of chemotherapies that have come out over the last few years for some of these cancers, but again, that it's still a very difficult condition to treat completely.
How might a patient know or suspect that they have leiomyosarcoma?
Yeah, that's difficult because we don't have a reliable blood test
Mhm.
or way of imaging that tells us for sure whether they're a sarcoma or not. Fibroids, when they grow larger faster, people used to think, oh, we're worried about sarcoma. And that's true if you're postmenopausal that's a red flag. If somebody's postmenopausal and has a fibroid growing rapidly, that's a problem. But for the 40-year-old that's not menopausal and has a rapidly growing fibroid, studies have shown no correlation whether that's a leiomyosarcoma or a benign fibroid. There's nothing accurate with MRI. There's some people who think, they see irregularities of the fibroid and have a hint, but even that has not been shown to be reliable. So unfortunately, there's not a great test to figure out what's benign and what's cancerous before doing surgery.
So there's no way to know, but we do a risk factor based approach, postmenopausal growth in menopause, certain family history for cancer. We look at the potentially rapid growth LDH3 isoenzyme, some MRI findings, but none of those independently say yes or no. In fact, even collectively they don't, but we have to just take all of that data, put it together and decide what the patient's risk is.
Exactly. That's the best we can do right now.
Well, I certainly want to thank you for taking the time and helping us provide up-to-date, valuable healthcare information. I know that there's a need for that, and we really appreciate you taking the time.
Yeah, thanks, Rich. It's my pleasure, and I think this forum is great, and it's great to be able to talk to lots of people. So thank you for including me.
So, if something that we've discussed today has sparked your interest, please go ahead and subscribe and share. Again, a big thank you for Marc Winters for helping us tackle this difficult topic. If people wanted to get a hold of you, what's the best way to do that?
Probably the easiest way is through my practice website, which is ocwmg.com.
All right, and that'll be included in the description section below. Thanks again, and tune in next time.